Good morning, all of you. At the outset, let me thank the organizing committee of APOS and the AIOS for giving me the opportunity of delivering this prestigious Dr. Rednam Surya Prasadra oration. Even though I'll be talking about a small topic, it is definitely important to know something about this corneal graft rejection. Just to reduce the corneal blindness. So, and if you see out of many causes of the blindness, corneal blindness is one of the leading cause of blindness in the world. And according to the WHO reports, the whole world population is suffering with 5% of corneal blindness. So this is the report from the WHO, and these are the causes of important causes of the corneal blindness, and out of which the bullous keratopathy, aphakic bullous keratopathy, pseudophakic bullous keratopathy, or post-operatively, they are all iatrogenic causes, and the other causes for corneal blindness is like corneal opacities, dystrophies, corneal injuries, and then congenital abnormalities. So this is the list of the corneal blindness, and definitely it constitutes one of the important causes of the total blindness. And to combat this blindness, if you see the statistics, there are around 40,000 ophthalmos all over approximately all over in India, and there are 764 eye banks, and the only functioning eye banks are around 220. So the corneal blindness is heavy, and if you see the figures, statistical figures, 68 lakh people are suffering with corneal blindness, and in that at least 11 lakh people are blind bilaterally because of the corneal diseases. So on an average, 40 to 50% of the corneal donations are used for transplantations, and more than 1 lakh corneal transplants are required in India annually. Whereas the corneal transplantations are done every year, we are doing only approximately 25,000, and 30,000 eyes are collected every year. So the demand is more, whereas the supply is less. So the current annual transplant, as I told you, is only 25,000. 30,000 new cases of corneal blindness are added to the burden, and nearly there are around 1,000 corneal surgeons are there, and out of which only 400 are involved in the grafting work. Now I will go on to the subject proper, that is corneal graft rejection and failures, and we have to understand what is definitely the difference between corneal graft rejection as well as the failure. By definition, corneal graft rejection is an active process wherein there will be a complex immunological reaction from the host antigens against the donor corneal tissue, ultimately leading to decompensation of the cornea. The grafted cornea should be clear for at least 10 to 15 days to say it is a corneal graft rejection. Otherwise, by definition, you cannot say. Immediately, if you see post-operatively, whether it's corneal edema on the day one, we cannot label it as a corneal graft rejection. So, once if there is failed cornea, it is failed forever. Whereas a corneal graft rejection, if you treat it at a prompt time, prompt treatment and then correct treatment, it will definitely go back to the normal stage, clear cornea, whereas unlike the corneal graft failure, once if the graft is failed, it is failed forever. And by definition, if you want to know what is graft failure, primary graft failure is defined as corneal edema that never clears from the immediate post-operative period secondary to inherent deficiency in the donor graft or surgical trauma or during transportation and improperly stored tissues. So this is the definition. It's not related to corneal graft failure, is not related to graft rejection. This is something different, whereas graft rejection is an immunological reaction. All these human organs transplantations are governed by an act, we call it the Human Organ Transplantation Act, established in the year 1994 by the Government of India, and it covers all the ethical aspects, social, financial, and humanitarian aspects of the organ transplantation. And the government of Andhra Pradesh has started this Jeevan Dan program, which includes also this cornea. And this is in general the types of grafts. Of course, all of us know that there are 4 varieties. Autograft is within the same individual, isograft between the twins, and then allograft is from the same species, another individual, xenograft is different species. These are the 4 varieties. But we are concerned with the corneal types of the corneal graft rejection. Before that, I want to tell about the types of keratoplasty. Basically, there are only 2 varieties of corneal grafting, full thickness keratoplasty and lamellar keratoplasty. For the last 2 decades, there are so many advances in the lamellar keratoplasties, namely deep anterior lamellar keratoplasty, Desmet stripping endothelial keratoplasty, and you have DMAC. Right, just now Dr. Basak has told DVEC and then DSS, so many advances. See, layer by layer, the cornea is being taken and it is given to the needy patients. Whatever tissue is needed, that is taken and then transplanted to the needy patients. So this type of component keratoplasty has given a wonderful success rate for the corneal transplantations, unlike the penetrating keratoplasty. And in general, these are the types of graft rejection. You have hyperacute and then acute, chronic. This is in general. But as far as the corneal graft rejection is concerned, you have basically epithelial rejection, chronic stromal rejection, hyperacute stromal, chronic focal endothelial, and combined stromal and endo. You have a combined type of rejection, including all these layers. So this is the types of corneal graft rejections. Little bit about the characteristic features of the rejections. Epithelial rejection, you can this slide is showing the junction between the host and graft, and the epithelium is, if you observe this epithelial rejection, the epithelium is hazy with little infiltrations, and some spots are there seen in the between the subepithelial layers, and they are called as KS spots. Here the slide is showing the host graft junction, and the another one is stromal rejection. The stromal rejection is characterized by the infiltration of the antestroma or deep stroma, and these lesions just mimic the adenoviral lesions, just the lesions of the adenoviral or any other herpetic lesion. There is a similarity between these lesions and then stromal rejection, but of course it is a immunological reaction. This, if the stromal rejection is superficial, it may not lead to a rejection, but if the entire stroma is involved, it can definitely lead to graft failure. And you have hyperacute stromal rejection, and this is characterized by a layer of haziness advancing to the center of the graft through 360 degrees slowly, involving the stroma. And it is having a special features, like sometimes it may be looking just like the corneal abscess because of the severity of the rejection. And finally you have endothelial rejections. So endothelial rejection is characterized by an advancing line, which is nothing but the lymphocyte and the immunological cells involved, and you have a clear cornea between the advancing line and then the other part of the donor cornea. The same thing, endothelial rejection. And here are some slides showing the various varieties of graft rejection. This one is the initial stages of the epithelial rejection. You can see at the host graft junction, the suture tracts are having some whitish spots, and this is the leading part of the immunological reaction. And this slide is showing the subepithelial infiltrates. This is endothelial rejection. We call this line as a choreoblast line, and it's nothing but graft rejection line advancing toward the center. And at the periphery, you can see the new vessels coming onto the cornea and progressing towards the center. And this is another slide showing the same thing. And subepithelial spots, they are called as Crackmer spot, nothing but cell infiltration, immunological cell infiltration subepithelially. As this is the most worst case of the graft rejection, showing the keratic precipitates at the back of the cornea endothelium, and there is AC flagrant cells. The entire cornea is going to be rejected soon in this case. So this slide showing total graft rejection, and this one is the endothelial line, the rejection line. Sometimes you can see a combination of all these things, endothelial rejection as well as the stromal and then the epithelial rejections. This is badly rejected cornea, full thickness involving all the layers. As I told you, the difference between the graft failure and graft rejection. In the graft failure, there will be edema maybe from the first day, second day. This is one of the slides showing the graft failure, corneal edema not resolving, and then later leading to corneal decompensation. This is a badly spoiled cornea with vascularization. You should not take this for corneal grafting. It's a high risk case. Now, why the cornea will get rejected? If you see, you can divide the risk factors into donor factors, host factors, technical factors, and then sometimes the post-operative factors can also lead to graft rejection. Or you can also divide the causes or risk factors of graft rejection is like preoperative, postoperative, and then paraoperative. Like that, you can divide, and the details of these risk factors. As far as the donor tissue is concerned, you have say donor factors having, suppose if there is antigen overload or the histo incompatibility as far as the HLA and ABO blood group is concerned, even the gender is also involved, duration of the tissue storage, the technique of the taking corneal button, and then the vaccination status of the donor, all these things matter. And the host factors, many causes are there where the cornea get rejected, and the examples for corneal factors are like vascularization of the cornea, as I showed you in the previous slide, and the regrafts or failed grafts is other risk factors. And the other risk factors as far as the host is concerned, you see the patients who have undergone excimer lasers, ABO incompatibility, or the people are having ocular surface disease like dry eye, chemical injury, Lyme injury. All these things are very risk factors for the development of corneal rejection. Some more risk factors, the patients are using pilocarpine or having uncontrolled glaucoma, undergone ag laser capsulotomy, and the large grafts, interstitial keratitis. Again, they are all the predisposing, the risk factors for the corneal graft rejection. Sometimes even the eccentric grafts, large grafts, presence of anti-synic, bilateral graft, loose sutures, previous anti-segment surgeries, they are also the risk factors for the development of corneal graft rejection. Post-operatively irritating exposed suture edges, and if there is some blepharitis, trichiasis, entropion, and then the vascularization, all these are also post-operative causes for the development of corneal graft rejection. So all the risk factors are tabulated here. Just now I have covered all the risk factors, and as far as the risk is concerned, corneal graft risk, it can be divided into low risk, high risk, and then medium risk. High risk the patients will be having the diseases like if the cornea is exposed for the chemicals, and if the cornea is having the viral keratitis, vitrectomized patients, active keratitis, and then the keratoplasty in children, they all come under high risk corneal grafting, whereas the graft will be very nice and clear in case of low risk factor like corneal dystrophies, keratoconus, and central cornea without any vascularization. So you can preoperatively you can check definitely whether some patient is going to have high risk graft rejection or low risk. This is another tabular form depicting all the risk factors of graft rejection as well as graft survival. Now, so it is important to know the signs and symptoms of graft rejection. not only the doctor, the treating doctor, even the patient should be educated regarding the signs of rejection, and we have to educate the patient so that he can come at early time for the treatment, so that we can give a good treatment, and we can definitely give a clear cornea. Patient compliance, patient follow-up is very important. As far as the symptoms are concerned, regarding the graft rejection, there will be redness, pain, photophobia, and then diminution of vision. And as I showed you in these slides, the several signs you can see, if not in the initial stage, maybe after some time of the graft rejection, you can see the signs of the graft rejection, like chemosis, conjunctival congestion, ciliary congestion, raised intraocular pressure. We can see stromal and subepithelial infiltration, endothelial rejection, and chordodust line. Now, coming to immunopathology, this is cornea is very tricky tissue as far as the immunopathology and the immunopathology of the graft rejection is concerned. We all know that the cornea is not having blood vessels and not having lymphatics, and it is having a special soluble proteins like we call it echoid anti-chamber associated immune deviation. They are all helpful for not developing the immunological reaction, all these things. Despite of all these things, some patients will develop graft rejection, and these are of course, it's very difficult to remember all these names of the complement cascade of reaction in immunological process. But if you go through the cellular immunology, definitely you will understand. And as I told you, despite of the presence of all these things, echoid vascularity, and then the lack of lymphatic, some grafts will get rejected. And the reason being, now if you see the pathophysiology, after some time of the grafting, there will be, say around 2 months, 3 months, there will be slow development of the vascularization. Through the vascularization, the immune cells will come onto the donor cornea, and there happens antigen and antibody reactions. And especially the major histocompatibility class 2 antigen and are related to immunological rejection of the graft. CD4 cells, CD8 cells, they get stimulated, they go to the lymph nodes, and there the memory comes to these cells, the immunological cells, and again they enter into the blood vasculatures, and it is a vicious circle. After sometimes maybe around 3-4 months, sometimes it may be even 1 year for it takes 1 year for the graft rejection. So if you understand the process of graft rejection, definitely we can treat at the beginning stage, or as you can after some time, even at the end stage also you can try with the latest drugs. So this is a clear graft, this is a failed graft, of course, and some diseases just mimics the corneal graft rejection, namely a late graft failure and sterile endophthalmitis are examples for the differential diagnosis of graft rejection. We will think that it is a graft rejection, but it is something different, like epithelial downgrowth, recurrent herpetic keratitis. They all come under differential diagnosis. They are really they are not the features of the graft rejection. There is a differential diagnosis. Now let us see something about the final part, that is the management of the corneal graft rejection. And see, all the studies we have comes from the registries like Australian Corneal Transplant Registry. They are retrospective studies, Singapore, UK transplant studies, and you have corneal transplant collaborative studies, and then corneal graft rejection treatment follow-up studies. Now, the most important factor regarding the management is, like, you have for a routine graft rejection cases with a low risk, you can start with the local steroid like prednisolone drops and dexamethasone, and even systemic steroids according to the body weight. And if you think the graft rejection is very high, severe, you can go with IVMP, methylprednisolone pulse therapy. And later on, we can try the combination of steroids with cytotoxic agents like azathioprine and cyclosporine. Newer modalities have come in the management of the corneal graft rejection, severe graft rejection, apart from the cytotoxic agents and then steroids. People are trying with the tacrolimus, zero point 0.6 milligrams kg body weight, both the drops as well as the ointment forms are. The other drugs are like ripamycin, deoxyspergolene. These are all the drugs used for preventing the corneal graft rejections. The latest one is cord blood stem cell culture. Human organs are tried for the replacement of the epithelium and then the endothelial cells with the help of cryobanking, bionic organs. And to summarize, recent invention, the component layer by layer corneal lamellar keratoplasty has revolutionized the success rate of corneal transplantation with the corneal component layer by layer surgery. Corneal graft rejection rate has come down to 0.1 to 0.5. And some other the modalities of treatment, even before the surgery, UV light treatment of the cornea, and then the tissue cultures, epithelial and endothelial cultures are used, pachymetry, and as I told you, the tacrolimus and cyclosporin drugs are used for the prevention of the corneal graft rejection, apart from ripamycin and DSG and Segra. Anti-VEGF drugs are used for preventing the vascularization like bevacizumab, once if there is, the surgeon notes vascularization of the periphery. So thank you one and all for your patient listening and kind attention.